Congenital heart disease. Dr. Sidi Asha Abid Majid. Family Medicine Trainee, PUCM. Objectives. Recognize the various presentations and causes of congenital heart conditions at birth, during infancy and childhood period. Manage and follow up congenital heart conditions in children. Refer appropriately children with congenital heart diseases to the pediatrician. Overview. Congenital heart disease, CHD, the most common congenital disorder in newborns, 6 to 21 per 1,000 live births. In preterm infants 2 to 3 times greater than term infants. One of the leading causes of perinatal and infant death from congenital malformations. UK Northern Congenital Abnormality Survey. Anatomy of the heart: 4 chambers, 4 valves, RA, RVLA, LV. Mitral, bicuspid, tricuspid, aortic, pulmonary. Anatomy of the heart: 5 great vessels, deoxygenated blood, SVC, IVC, pulm artery, pulmonary vein, aorta, deoxygenated blood. From SVC plus IVC, RA, RV, pulm artery, lungs, oxygenated blood. From pulm vein, LA, LV, aorta. Systemic circulation, fetal circulation. In utero, placenta acts as the lungs, therefore less blood passes into the actual fetal lungs. 2 structures within a fetal heart that allow this bypass. Patent ductus arteriosus. Foramen oval. Fetal circulation. PDA allows mixing between the pulmonary artery and the aorta, as it is a passageway between these 2 major vessels. PFO is a hole between the 2 atriums. It allows mixing of blood between the 2 right and left atrium. Fetal circulation. The pressure in the lungs of a fetus is higher than that in the body. This increased pressure encourages the right to left shunt. After a baby is born, the pressure in the lungs decreases as the vessels in the lungs begin to relax. This change in the pressures allows more blood to flow into the lungs. The changes in pressure cause the PDA and PFO to eventually close. The final closure usually takes several days. AHA classification of CHD. Septal defects. ASD. VSD. Obstructive defects. As PS. COA. Cyanotic defects. TOF. TGA. Tricuspid atresia. Pulmonary atresia. Truncus arteriosus. TAPC. HLHS, ASD. Opening in the atrial septum permitting free communication of blood between the atria. 10% of all CHD. Hemodynamics. Lieutenant right shunt. Increased blood flow into RA, enlarged RA plus RV. Pulm HPT. VSD. Opening in the ventricular septum, which allows free communication between the right and lieutenant ventricles. 20 to 25% of all CHD. Hemodynamics. Lieutenant right shunt. Increased blood flow into RV, enlarged RV. Pulm HPT, aortic stenosis, as. Aortic stenosis, as 5% of all CHD. Narrowing of the aortic valve. Depending on the severity of the stenosis, the symptoms at birth can vary from none to decreased blood flow and decreased oxygenation to the systemic circulation. Pulmonary stenosis, PS. 5 to 8% of all CHD. Narrowing of the pulmonary valve. Hemodynamics. RV pressure hypertrophy, RV failure. RV pressures may be greater than systemic pressure. Post-stenotic dilation of main PA. W/intact septum and severe stenosis RL shunt through PFO cyanosis. Cyanosis is indicative of critical PS. Coarctation of aorta, COA. An obstruction to the outflow from the left ventricle at or near the aortic valve that causes a systolic pressure gradient of more than 10 mm of mercury. 7% of CHD. 3 types. Valvular, most common. Subvalvular subaortic, involves the left outflow tract. Supravalvular, involves the ascending aorta, is the least common. Hemodynamics. Obstruction of left ventricular outflow pressure, hypertrophy of the LV. Tetralogy of Fallot, TOF. TOF, stenosis of the pulmonary artery, interventricular communication. Deviation of the origin of the aorta to the right. Hypertrophy, almost always concentric in type, of the right ventricle. Failure of obliteration of the foramen oval may occasionally be added in a wholly accessory manner. Fallot, Etienne Louis Arthur. Contribution to the pathologic anatomy of morbus caeruleus, cardiac cyanosis. Marseille Med. 1888, 25 to 418 to 20. Transposition of great arteries, TGA. TGA. 5% of all CHD. The aorta is connected to the right ventricle, rather than the left, so instead of pumping blood to the lungs it pumps it back to the body. On the left side of the heart the pulmonary artery is connected to the left ventricle, which pumps the blood that returns from the lungs back to the lungs. There are 2 separate circuits at work. One handles and recirculates the unoxygenated blood from and to the body, the other handles and recirculates the oxygenated blood from and to the lungs. These babies need the PFO and PDA to remain open, so there is mixing of oxygenated blood with unoxygenated blood. Tricuspid atresia. Tricuspid atresia equals blocked. Right atrium is unable to allow blood flow into the right ventricle because the tricuspid valve is blocked. Since the right ventricle has not been working, it becomes smaller in size and underdeveloped. This defect may be seen with a single ventricle, which means instead of a left and right ventricle there is just one large ventricle. The survival of an infant with tricuspid atresia is dependent on communication between the right and left atriums via an ASD, VSD or PFO. Pulmonary atresia, less than 1% of all CHD. PA plus VSD equals a feature of TOF. PA plus no VSD equals hypoplastic right ventricle. The PFO allows mixing of unoxygenated blood from the right to mix with oxygenated blood on the left. The PDA or patent ductus arteriosus, also a normal fetal structure, also allows for mixing of blood, which provides a means to get blood to the lungs after the baby is born. Truncus arteriosus. Truncus arteriosus, less than 1% of all CHD. Combination of the aorta and pulmonary artery into one large arterial vessel rather than 2. This large, single vessel usually sits above a large VSD, AW valve abnormalities. The result of the common aorta and pulmonary artery is unrestricted left-to-right shunting, which cause congestive heart failure, CHF, total anomalous pulmonary venous connection, TAVC. 1% of all CHD. Some or all of the pulmonary veins are abnormally connected and drain into the right atrium. These babies are dependent on the fetal circulation remaining intact after delivery. Blood passing through the PFO allows for filling of the left atrium. The oxygen-rich blood in the pulmonary veins mixes with the oxygen-depleted blood normally found in the right atrium. This is the blood that flows into the left atrium. From the left atrium the blood goes into the left ventricle and is then pumped to the body via the aorta. The mixed blood that is pumped out through the aorta to the body is usually quite low in oxygen. Hypoplastic left heart syndrome, HLHS. 1 to 2% of all CHD. With this syndrome the left side of the heart is smaller than normal. The structures affected can include the left ventricle, the mitral and aortic valve, as well as the aorta. These babies are dependent on the fetal circulation remaining intact after delivery. For oxygenated blood to reach the body, the right ventricle pumps the blood into the pulmonary artery and some of this blood passes through the PDA, patent ductus arteriosus, into the aorta and eventually to the body. Critical CHD. CHD requiring surgery or catheter-based intervention in the first year of life. High risk of mortality and morbidity when there is delay in DX and referral to tertiary center. 25% of those with CHD. Timing of presentation. At birth, presence with serious life-threatening clinical findings, immediate intervention. After discharge, diagnosis missed prior to discharge as the infants appear normal on routine examination. ESP and ductal-dependent lesions. Ductal-dependent lesions. Coarctation of aorta. Interrupted aortic arch. Aortic stenosis. HLHS, hypoplastic left heart syndrome. TGA, transposition of the great artery. Trunsus arteriosus. TOF, tetralogy of Fallot. Total anomalous pulmonary venous connection. Presentations at birth. No symptoms. Shock. Cyanosis, detected when the concentration of reduced Hb is 4 to 5 grams/dl. Severe pulmonary edema resulting in tachypnea and increased work of breathing. History: maternal DM and/or obesity increase the risk of CHD. Smoking in the first trimester. Congenital infections, CMV, herpes virus, rubella, Coxsackie. Drugs: hydantoin, lithium, alcohol. ART, assisted reproductive therapy. Family HX. Cardiomyopathies, sudden death, unexpected death in infancy. 3x increased risk of CHD when first-degree relative has CHD. 15.2x for monozygotic twin. Physical examination: general cyanosis, pulse oximetry screening, SPO2. Tachypnea. Coughing and wheezing. Peripheral arterial pulses. Extracardiac abnormalities. Hyperoxia test. Physical examination: CVS, abnormal heart rate, thrill S2 splitting. Other heart sounds. Murmurs, innocent, pathologic? Absent of murmurs does not rule out CHD. The velocity of turbulent blood flow may not be high enough to generate a murmur. Decreased ventricular function can limit generation of murmur. Elevated pulmonary resistance may limit flow, may not be sufficient to be audible until the resistance has fallen. Later presentation symptoms: difficulty in feeding, limited milk intake. Feedings take too long. Frequent disruption of sleeping. Choking, gagging. Vomiting. Changes of color, pallor, central cyanosis. Excessive unexplained irritability. Excessive sweating, with feeding. Poor weight gain. Inactive, excessive sleeping. Signs. Central cyanosis. Pallor. Murmurs. Diminished or absent peripheral pulses, in COA. Presentations: infancy. Poor feeding. Lethargy and tiring with early stopping of feeds. Respiratory distress, tachypnea, wheezing. Trouble coordinating feeding and breathing. Irritability. Sweating while feeding. Poor weight gain, decreased caloric intake because of poor feeding and increased metabolic demands because of the underlying cardiac disease. Grunting, low-pitched sound generated when the infant closes the glottis. Hypoxemic spells, tet spells, are one of the hallmarks of severe tetralogy. Tet spells most commonly start around 4 to 6 months of age and are characterized by onset or deepening of cyanosis, sudden onset of dyspnea, alterations of consciousness, decrease in intensity of systolic murmur, presentations, children. Nonspecific symptoms: inability to keep up with peers, respiratory distress, sweating, diaphoresis, ESP with exertion, poor weight gain, chest pain, severe and crushing pain, radiates to arm/jaw, cardiac ischemia, retrosternal sharp, severe and constant pain, radiates to lieutenant shoulder pericarditis, severe, sharp and tearing pain, radiates towards the back BTWN scapula's dissecting aneurysm, exertion-induced chest discomfort, coronary heart disease or hypertrophic cardiomyopathy, chest pain, AW syncope or palpitation, tachyarrhythmias, fever, endocarditis, need to be considered in a febrile PT with a new or changing heart murmur, rheumatic fever, a sequela of group A streptococcal pharyngitis, can present with myocarditis or pericarditis. Kawasaki disease, should be considered in child with fever greater than 5 days, particularly if it is accompanied with rash, lymphadenopathy, conjunctivitis and distal extremity changes. The major complication, coronary artery aneurysm. Family history. Infant risk of CHD with affected parent, AVSD or TOF, 4%. Infant risk of CHD with an affected sibling, 2%. Byrne J., Brennan P., Little J., et al. Recurrence risks in offspring of adults with major heart defects, results from first cohort of British collaborative study. Lancet 1998, 351-311. Other heart diseases that have familial predisposition. Family dilated cardiomyopathy, hypertrophic cardiomyopathy, familial causes of sudden cardiac death, long QT syndrome. Physical findings: general HPT tachycardia. Causes: arrhythmia, SVT, VT, heart failure, lieutenant to right shunt disease. ECG is helpful in evaluating cause of tachycardia. Tachyarrhythmia, require urgent referral, risk for potentially life-threatening cardiac disease. HPT. Need to rule out COA, failure to thrive, febrile, as mentioned. Due to inadequate food intake, increased metabolic demands. Suggestive of cardiac cause if child easily tired while feeding, have SX of respi distress, murmurs plus. Poor perfusion, due to low cardiac output. CRT greater than 3 seconds. Cool extremities. Decreased peripheral pulses. May lead to shock, impending shock. Febrile, as mentioned. Respiratory abnormalities. Wheezing, primary pulmonary disease, cardiac disease, AW elevated lieutenant ventricular and diastolic pressure, pulm HPT. Tachypnea due to increased pulmonary blood flow, pulm. Venous congestion. B. Elevated lieutenant ventricular and diastolic pressure. Rales, heart failure, pulmonary overcirculation. Stridor, due to airway obstruction, caused by congenital vascular anomaly, e.g. vascular ring. Intensity less than GARD3, usually innocent, functional murmurs. CVS, findings that warrant referral to cardiologist. Findings. Nature. Diagnosis. Loud murmur, grade 3 or higher. Intensity less than guard 3, usually innocent, functional murmurs. Harsh murmur. ESM at upper lieutenant sternal border. Pulmonary stenosis. ESM at upper right sternal border. Aortic stenosis. Continuous murmur. PDA. Pansystolic murmur. PSM at lieutenant sternal border. VSD. Findings. Nature. Diagnosis. Diastolic murmur. Loud or single S2. Loud S2. Pulmonary HPT. Widely split S2. ASD. Gallop rhythm. Constant third heart sound. Cardiomyopathy, avenue incompetent valves, LR shunt disease. Friction rub. Sandpaper-like sounds. Pericarditis. Innocent, functional murmurs. Majority murmurs in infants/children. Due to turbulence across the branch pulmonary arteries that are not fully developed because of the relatively small amount of pulmonary blood flow in utero. Typically disappears by 6 months of age. Increase in size of the branch pulmonary arteries. Reduction in turbulence. Characters. AW quiet precordium. AW normal S2. Crescendo-decrescendo pattern. Intensity less than grade 3. Asymptomatic child. Managing children with CHD in primary care. Developmental issues. Feeding and growing. Medications. Immunization. Infective endocarditis prophylaxis. Developmental issues causes. Chronic disease. Genetic causes. On cardiopulmonary bypass. Denver 2 test, screen for cognitive and behavior in 4 developmental domains. 1/3 of children with CHD who required surgical or catheter intervention have GM, FM and social skills delay. Weinberg et al., 2001. School-aged children with HX of newborn cardiac surgery for complex CHD are at increased risk of inattention and hyperactivity. Schillingford et al., 2008. Feeding and growing. Infants with complex CHD often experience poor nutritional status due to poor feeding. Cherla et al., 2009. Parents' complaints: longer to feed, poor appetites, refuse to eat. It is important to plot the weight and length/height at every visit. Breastfeeding should be encouraged as long as there is weight gain. May consider to fortify with formula milk to make it 24 to 30 calories/Oz. Enteral feeding can be initiated through nasogastric tubes in infants who fail to gain weight despite being fed with fortified formula. Red flag: growth below 5th centile. Weight become disproportionate to their height. Rate of weight gain is less than 25% than the expected findings. Medications. To ensure the child take medications before and after the surgery. Should inquire the use of over-the-counter medication and check the interaction with current cardiac medications. Monitor if there are signs of renal insufficiency or drug toxicity to notify the cardiologist. Adjustment of drug doses because of weight gain also should be done in consultation with pediatric cardiologist. Immunization record should be reviewed. DiGeorge syndrome, caused by deletion of 22q11.2, result in immunocompromise. Associated cardiac defects, TOF, interrupted aortic arch, truncus arteriosus, pulmonary atresia. Immunology consultation is needed before the administration of live vaccines. Spleen provides primary immunologic defense by being a reservoir for T lymphocytes that initiate the production of IM, first AB produced in infection. A splenic PT should take prophylactic antibiotics and should receive all their scheduled immunizations. Price et al., 2007. OP recommends that prophylactic antibiotics be discontinued at 5 years of age, provided the child has not had pneumococcal infections and has received pneumococcal immunizations. OP Committee on Infectious Disease, 2000. Prophylaxis. American Heart Association, AHA, recommends maintaining oral health and hygiene with regular brushing, flossing and dental visits since age 1 year old. Prophylactic antibiotic prior to dental procedure are limited to children with artificial heart valves. Prevent checks of E. Serious CHD. Cyanotic heart disease. Urgent appropriate referral. In PT with or at imminent risk for hemodynamic compromise and death. Cardiogenic shock, central cyanosis, tachyarrhythmias, syncope. Timely. In PT with a suspected cardiac condition that may progress and has the potential to result in hemodynamic compromise, significant morbidity and become life-threatening over a period of weeks, months. Referral should not be more than a week. E.g., VST, PDA, TOF. Routine. PT with potential cardiac lesions that is unlikely to proceed to hemodynamic compromise and can over a matter of weeks. E.g., asymptomatic patient with a loud non-innocent murmur. Summary. Children with CHD can present a challenge to primary care practitioners. May require more focused attention on regular visits for health maintenance and prevention of illness. Timing of referral is based upon the risk the underlying suspected cardiac disease may progress and causing hemodynamic compromise, morbidity and mortality.